Living Seed Media brings to you God's Word, which is His comprehensive equipment for changing lives. May the Lord impact your heart as you encounter His Word. For further inquiry or counsel, contact Peace House, P.O. Box 971, Boko, Benue State, Nigeria. Telephone numbers 0703 0363659, 0703 7681198. Email address lsmedia@livingseed.org, or visit our website at www.livingseed.org. Let us sit back and listen as the servant of God brings forth the word of life.
It is now our singular honor. We wanted one keynote speaker, but now we have two keynote speakers. And you will be realizing why I am saying that in a short while. So permit me to invite off stage, first and foremost, Professor Eyitayo Lambo, and shortly after him, another keynote speaker will also come up. It is one of those rare occasions when we have opportunity to stand side by side, and when the junior is able to request the senior to keep standing while he's talking. To the glory of God our Father, I present him to us as he brings to us the keynote address on today's occasion. Thank you very much.
I thank you for asking me to speak on a subject that you have chosen for this summit: transforming Nigeria's healthcare delivery system, the challenges and the prospects. Before I was minister, if you asked me to talk about this, I could talk to you for 24 hours. But after being minister, if you ask me to talk about it, we can be here for the whole week. But I will not hold you for a week. I will not even hold you for a day. I will try and talk within the 1 hour that I have. And in doing so, I have the following agenda, the outline of the presentation. It's faint, but I'll just run through them. The first thing is I would like to define the concept of a health system. Secondly, I would like to talk about the building blocks of a health system. Thirdly, I would like to talk about the goals of a health system. Fourthly, I want to talk about what is expected of each health system's building block so that the goals of the health system can be realized. And when I talk about what is expected, that is like telling you what a perfect health system should be. And as I talk about this very briefly, you will be able to assess where we are with regard to this perfection standard in Nigeria. Then, sixthly, I will now talk about the prospects of transforming healthcare delivery system in Nigeria, in spite of the various challenges that I will have discussed in section 5. And lastly, I will also want to say to us and challenge us that we should believe that the transformation of Nigeria health system is doable. And indeed, that we have a short experience to share with you that show that if we continue on the right path for between 15 and 20 years, we can radically transform Nigeria's health system so that people who need health care, poor and rich, will not need to go outside this country. Now, the concept of health system. I need to give an operational definition, and the one I will give is exactly the one that WHO has given. And of course, you know that WHO has mandate for international health. So whatever they say is the gospel truth. Health system consists of people, institutions, and resources and actions whose primary intent is to do three things. One, to promote health. Two, to restore health. And thirdly, to maintain health. So when you talk about health system, some people think about the health facility alone. No. The health system consists of the people, and I'm happy about what Brother Gwile said yesterday. People, health workers, as well as health managers, and even politicians, political leaders, and so on and so forth. So the people, the institutions, and the resources, as well as actions that are taken. Now, so that we do not see health system as confined to what takes place in health facilities, I would like to add on to my definition that health system includes all the efforts that are made to influence the determinants of health, as well as the more direct health improving actions that are taken by you as individuals, by families, by communities, by the private and the public health sector. So it's it's a very, very wide definition. And finally, at times we think that health is only produced by the Ministry of Health. No. If Ministry of Health is doing everything, no matter as perfectly as possible, health ministry alone and health workers alone cannot deliver health. There are certain other things that must be available for the people of a country to be healthy. Water, road, sanitation, agric, and so on and so forth. All these are important if you want to produce health. And therefore, I would define health system to also include what I call and what WHO calls intersectoral action for health, where other sectors are brought into play. So that is my concept, by definition of the concept of health system. So by now, I hope you know what a health system is. The second thing is the building blocks of a health system. And again, I'm borrowing from WHO because, like I said, whatever they say about international health is final. We just have to conform. A health system has certain pillars, has certain building blocks, and there are 6 of them, which unfortunately is not clear, but I think maybe as many of you that want can approach Professor Mokolu so that you get a copy of the slides. These are the building blocks of a health system. Service delivery. That's important. 2, human resources. 3, medicines, vaccines, and technologies. We always put them together. Medicines, vaccines, and technologies. 4thly, financing. 5thly, information or health information system. And at the center of all this is leadership and governance. So I think I'll repeat this because they are very important. So the components or the pillars or the building blocks of a health system are service delivery, human resources, medicines, vaccines and technologies, financing, information, that's health information system, and the leadership and governance, which is at the center. You will see in that picture that is shown at the center that without that, because it is that leadership and governance that we put the 5 other blocks together. Okay? And of course, leadership and governance are people. So you have 2 blocks that deal with the people, the health workers as well as the leadership and the governance. So this is important. So if our health system is not working, people, our leaders and you workers contribute about 2/7 of the reasons why the system is not working. And that's why the charge of Brother Bile yesterday, to me, I think is very, very important. So that's what I say about that. Then the goals of a health system. This picture is not too clear, but I'll try and tell you what this is trying to say. On the left-hand side are the building blocks, which I've just mentioned to you, those 6 things. And in the middle, which I will explain to you in a minute, if things work out, if these 6 things are put together very well, those are the intermediate targets or goals that should be achieved. And on the right-hand side are the real overall goals. And I'll read it to you in a minute. These are the real overall goals of a health system. So let me try and now give you what the goals are. The overall goal of any health system in the world, and again this was defined by WHO, endorsed by the World Health Assembly. So the way we look at it here is the way they look at it in America, and so on and so forth. So the overall goal of a health system is to improve health and health equity. It's not just to improve the level of health of people, but to also ensure that there is equity in the health enjoyed by the people in the country, rich or poor, tall or short, male or female, and so on and so forth. This is very, very important that, thank you very much, sir, that a health system anywhere, thank you, sir, the health system anywhere in the world must improve health and health equity in ways that are responsive. That is, it must be done in ways that the system itself responds to the demands of the people. Not for the system to provide what is not demanded by the people. I hope you are understanding this. So the system must be responsive to the needs of the people. The system must be financially fair. What does that mean? That is, those who are able to pay for services. But those who are not able to pay for services are not denied services. And when I'm making all this definition, I want you to be applying these things to the Nigerian system to see where we are. I'm saying that a good health system must be responsive to the needs of the people. And you can be asking yourself, when we look at our national health system, is it responsive to the needs of the people? I leave it to you to answer the question. Is the health system financially fair in the sense that both the rich and the poor can access the services? Again, I don't want to answer the question for you. You are the workers, but I'm sure you know where we are. And a health system's overall goal must be to make the best or the most efficient use of available resources. Again, when you look at the resources we have in Nigeria, the health resources, humans, that is health workers, facilities, money, and so on and so forth. You can begin to think, are we making efficient use of the resources? So that is also very important. So these are the ultimate goal of a health system, to improve health and health equity in a way that is responsive, that is financially fair, and that is efficient. That is the overall goal. But before the overall, there is the intermediate goal. And there are the intermediate goals. And there are 4 of them. One is to provide greater access to services. Okay? Secondly, is to achieve greater coverage of the population. Thirdly, is to ensure that the services that are being provided are of top quality. And fourthly, is to ensure that the interventions are safe. Now let me just take one of these. I said quality. I said there are 4 of them. These are access, coverage, quality, and safety. And I always like to take this because you are health workers. At times, your own measure of quality, this is why the patient must be at the center of what you are doing. To many of you, you have a CT scan, you have an MRI, you have this, state-of-the-art equipment. And so you say, oh, I'm providing quality services. Yes, you are measuring quality of services from your professional angle. You should also measure quality of services from whose angle? From the patient. This is very critical. And this is not what we are not doing this. I say that as a former minister, I say that as a researcher, and until we do this, we will not get to the promised land. It's not a cause. We worry more about the gadgets than the patient. And the attitude, and I think Brother Billy said this yesterday, the attitude is very, very important. To me, as a consumer, to any consumer, sophisticated or not sophisticated, one thing that is critical is the attitude of the health worker. A situation whereby a health worker goes to a health facility, he has stomach trouble. Okay? He now leaves the health center, the stomach trouble is still there. But in the meantime, he has acquired headache. It's not good enough. How does he acquire headache? You go to the facility, private or public, and let's talk frankly, it still happens. Greets the people there, and the receptionist look at him. It's as if you have had a quarrel before. As if that was not enough. By the time he meets the nurse, oh no, about, as Yorubas would say, it's like a war. And the poor patient now say, where did I meet this person before? Why is this person taking it on me? So, gradually that person is developing headache. So he goes back with combined honors. He came in with single honors. That is with stomach trouble. Now he's going back with the stomach trouble as well as the headache. You see what the attitude can do. Whereas you go to some other system, there are some of our providers who are doing this. I'm not running down anybody's place. But we must be frank. Unless we can speak frankly to ourselves, we will not be able to solve our problems. By the time you see, I know they will get their money. England or US or even some developing countries. You go in and you see the health worker. He interviews you, he or she interviews you before you see the doctor. It's as if you have known yourselves before. You're putting confidence into that patient. And of course, by the time he sees all the health providers, he's now very, very confident that, look, I know God will do it, but I know God is also sending these people to take care of my problem. That has to be there. Now, I will say this and underscore it. Thank God during the time we were there, we were able to refurbish the teaching hospitals, 8 of them, and by now almost all of them are refurbished. State-of-the-art equipment is there. But I keep on saying that state-of-the-art equipment alone cannot deliver quality services. What do we need? We need health workers who are state-of-the-art themselves. Okay, so that is very important. That is a message that I want you to take away from here. That we cannot, transform the health system without you. You are so critical. If other things are there and you are not there, then we are just wasting our time. So that is why I say, clap for yourself. You are doing a good job now. But I'm saying you can do better. So clap for that too. Okay. Thank you very much. Now, so I have given you the goals of a health system. Well, I'll try and keep within the time, like I said. I will have to fly if possible. Now I'm in section 4, so it's not, we are making progress. Although we are not at the center yet. If a health system is working very, very well, let me just give you the ideal situation with respect to each of the 6 components. Very quickly. Health services. Don't forget that is one of the components. You remember? Okay. The health services must be efficiently produced. Efficiently produced. It must be safe. It must be effective. It must be of good quality. And it must be accessible to the population. Look at all the adjectives. I'm talking about the ideal situation with respect to that pillar, that block of health service. I repeat. The health services must be efficiently produced. That is, you don't waste resources. It must be safe. It must be effective. It must be of good quality. It must be accessible to the population. So, we leave it there. We are going to assess our Nigerian health system, look at the challenges of health system in Nigeria with respect to each of these pillars. So it's important for you to know what I say the ideal situation is. Now, human resources for health. That's another, you should write that down because that relates to you. You must be available in adequate number. I'm sure you will agree with me. Any objection to that? You must be available in adequate mix. A country that overproduces doctors and you don't have enough nurses, you don't have enough lab scientists, you don't have enough pharmacists and so on, even medical records officers and so on. That is not good enough because everybody has a role to play. If you go back to Alma Ata, provision of health services was seen as what? A team work. A team must have a leader, and invariably the leader is the doctor, but they say a tree does not make a forest. Everybody has a role to play. You cannot say your role is better than my role. I think maybe one of the reasons why, and I'm coming to that, why I was accepted, quote unquote, as a minister, not being a medical doctor, was the fact that I don't belong to any of you. I remember when finally we had prayed, God let this cup pass over us, because I was earning good salary in Abuja here after retiring twice, and I was being paid pound sterling in Abuja. Double what I was getting in WHO. Then they asked for my CV. I said, CV for what? They say, appointment as minister. I said, Mba, not me as minister. I don't talk. I don't dine with politicians. But the rest is history. But what I'm saying is that, no, I think I should say this. We were then invited. I got a call from the Chief of Staff on a Friday, and he said, Professor, you are invited to meet with Mr. President, the Vice President, and the Chairman of the party on Monday. He is going to see you people one-on-one, 10 minutes to 15 minutes. Oh, yeah? So I went. And I came in, Baba, Eyitayo, as if we had known ourselves before. That's my first name. Tell us in 5 minutes your life history. Of course, I can tell you that in a month. I can tell you that in 1 hour. I even have 1 minute, resume of that. So 5 minutes, I blah, 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 I went through. So, so Baba said, Eyitayo, before you came in, give me your background. I was thinking of sending you to one of the economic sectors, like finance, commerce, and what is your reaction to that? So I said, Your Excellency, if I'm found appointable as minister, you are the boss. So you tell me where to go. But since the Holy Spirit is with me, and the Holy Spirit has made you ask me that question, you want my input into that. I said, sir, I would like to go to where I have comparative advantage. He said, that's why I want to send you to an economic sector. I said, no, sir. Where I have comparative advantage is health. He looked at me. He said, well, you are not a doctor. You are not a pharmacist. You are not a nurse. So I said, Your Excellency, you want a minister of health, not a minister of medicine. You are not hiring me to go and perform operations in national hospital or whatever. You are employing me to manage the economic sector for you. And what is relevant is a good knowledge of the health sector and strategic thinking, strategic management. He said, say that again. So I repeated that. The rest is history. He then said, okay, you go to Senate and you go and face them. And of course, when I went to Senate, funny enough, I said, but every day of my life is a testimony. I was still saying, God, if this is not of you, let something stop it. Then after I was introduced, questions. And people put up their questions, about 20-something of them. And the first person to be recognized was a student of mine in Ibadan, in Ilorin. I don't know how it just happened. It's God. So he asked a question, deliberately asked a question. It's as if, your background is economics operations research. How come when we look at your CV, is help here, help there, is help from top to bottom, from bottom to up, top to bottom. Can you give us an insight? So I went to town. And after talking for 20 minutes, they said, is it the wish of Senate to allow this guy to take a bow and go? They said, yes. So that was how I became minister. Now, the point I'm making here is that, and I'm jumping because I will come and address it again. It is critically important. And I'm sure many of you who are here, there was a concept I always used. I said, enough of what? Can anybody remember it? Enough of beauty contest. It is not just rivalry that we have among professionals. It is really beauty contest. And please, we have to stop that. Because everybody has a role to play. If one is missing, the others cannot substitute for them. That is another message I want you to take from here. You are all important. But there must be a team leader. I agree to that. Okay, let's go back. So human resources for help must be adequate in number, in mix, and in skill. They must also be well distributed within the country. A situation where you have all of them in Lagos. When people in Isanlu, which is the center of Nigeria, how many of you know Isanlu? Isanlu is the center of Nigeria. We are still going to contest. Abuja should not be the capital. It should be Isanlu. So they must be geographically distributed between urban and rural areas. And this is very important. They must be highly motivated so that they will not frown when they are working. So those are very important. And again, like I said, you can assess what is happening in Nigeria with respect to some of these ideal things that I'm mentioning. Health information, quickly. The health information system must ensure the production, the analysis, the dissemination and use of reliable and timely information on health determinants, on health system performance and health status. That is, the records must be there. Everything we want to know about health determinants, health system performance, and health status, we must have data to be able to say this is where we are. Which means that from the facility level, there must be a flow of information from the facility to the local government, from local government to the state, from the state to the federal. So that when we are talking about number of deliveries in a year, we have the accurate record. How many deaths? We have the accurate record. And so on and so forth. You will agree with me that we don't have that for now. Then we move on to health financing. This pillar is saying that we must raise adequate, reliable, and sustainable money from various sources, not just from one source. We must raise enough money. It must be sustainable. It must be reliable, so as to ensure that people can use services that they need, and also that people are protected from what we call financial catastrophe. And what that means, or impoverishment, what that means is that if you have a system whereby when people sick, and it's still happening, the only cocoa farm they have to sell that to get money to be able to treat themselves. Or a young, beautiful girl who is only 16 years old, very promising. You now have to quickly look for somebody to marry that girl, give you the dowry, so that with the dowry, you can go and take care of your health. That is not good enough. But that is happening. There are many farmers who have to use their farm to pledge to get money to be able to treat themselves. So that cannot be seen as financially fair. Because what happens is when people are sick and they cannot pay, people are poor already. Sickness, does it make them richer? No, it makes them poorer. But where you have a system whereby if you are sick, the state can take care of you. You get the point I'm making? Because health is wealth. If you are not healthy, you will not be able to generate wealth. And even if you generate wealth, if you are not healthy, you will not be able to enjoy your wealth. So, for a system, for the financing system we are talking about, must be one where if you are poor, there is a way you are taken care of by government or by one means or the other. We used to rely on what we call social network before. But do you believe that that is breaking down now? When we were growing up, many of you were growing up, the kind of solidarity you had in the family is not there now. Our children are more independent than anything. They are thinking Oyibo like now. During our own generation is the worst, in one sense. Our generation, we're taking care of our parents. We're taking care of our children. We are now even taking care of their children. But they are thinking about themselves. Okay? So, that social cohesion is no longer there. And a country must have a financial system for healthcare in place that takes care of this. Medical products, quickly, I will run through this. Medical products, vaccines, and technologies, this must ensure equitable access to essential medical products, to vaccines, and to technologies of assured quality, safety, efficiency, and cost effectiveness. That is the kind of thing that we should have if we have a good system in place. Lastly, on the pillars, leadership, governance. The ideal situation is that it must ensure the development and implementation of strategic policy framework and plans. Okay? The leadership, the governance must have a vision for the health sector. And in that, following the vision, they should develop policy and translate the policy into plans so that we know where we are going. Also, the leadership and governance must guarantee effective oversight. Regulation must be in place. Partnership building must be in place. Accountability and transparency must be in place. Do we have that? I leave it to you to answer the question. So I have given you the characteristics of each of the pillars if we must get to the promised land. And the promised land is where everybody has access, physical access, financial access to quality health services. Quickly, I didn't look at my time when I started, but I believe I still have about 15 minutes more. I'll run through it. I needed a day. Let me take them one by one. Service delivery. And give you some of the highlights. Some of these things were there when I was minister about 5 years ago. Even when we started. They are still there up till today. And the reason why they are still there up till today, some of them might be reducing in terms of intensity. And I will talk about that. Is we have a malady in this country whereby there is no continuity. And I say it again. No continuity. There is policy somersault. A government is there for 4 years. The leadership changes. The succeeding leadership doesn't want to touch anything that happened before. Are you with me? Whether you believe it or not, that is what is happening. And I will give you many examples to show this. And you cannot make progress because no matter how bad a preceding leadership has been, there must be one thing that leadership has done rightly. So what do? Build on that, and the ones that are wrongly done, you correct them. That is how to make progress. But a situation whereby the policy, well-designed policy, and this was one of the things we did when we were there for those 4 years. There is no policy you can think of that Nigeria needs that we didn't develop. All we needed was for succeeding governments to now implement. But you know what happened? Not only the health sector, even in the other sectors, some of the earlier government policies were jettisoned. And you begin again. BA will not take you anywhere. Begin again. We have to find a way of building on what has been achieved by a preceding government in order to make progress. So now let me catalog a number of the things we still have around. service delivery, for example. The following are the weaknesses that we still have up till tomorrow. The provision of services is still curative biased. I'm sure you agree with me. How much of prevention are you doing in the primary healthcare level? The primary healthcare level is dead. It is dead. I had, when I was minister, I wanted to go to all the states. I was able to go, because of the assignments in Abuja, I was able to go to only 15 states. And what I saw in primary healthcare facilities was a disaster. I come from a state. In my town, I know how many primary healthcare facilities we have there. They don't work. And it's because they are not working. That is why I decided to create a foundation to be able to do, because of government irresponsibility, we decided to be responsible and do for the people what government has failed to do for them. You go to those facilities, the health workers are there or they are not there. Even if they are there, they are paid half-month salary, 2-3 months ago. They don't have things to work with and so on and so forth. So the primary healthcare facility is not working. If it is not working, you have 3 levels of, you have 3 layers of in the healthcare delivery system: primary, secondary, tertiary. If the primary one is working in a country like Nigeria, given the disease pattern that we have, an efficient primary healthcare system can see 85% of the health problems that we have in this country. It is empirically validated. 85% of the problems. With only 15% going to secondary. And out of this 15%, it's not more than 2% that should even surface at the tertiary. How many of you are from teaching hospitals here? Please, let me see. If you go to your outpatient clinic, do you see malaria cases? Do you see cholera? Are you supposed to see them there? That's just an example. So resources are being wasted. People have lost confidence in the primary healthcare facilities. If you go to the government hospitals, the government hospitals are in prostrate conditions in many of the states. We have a general hospital in my town. It's incredible. One doctor, the doctor giving less than 25,000 naira a year to run the hospital, and so on and so forth. What do I expect to get? So, what I'm trying to say here is that not only do we have the 3 levels where they are providing services, they are concentrating on curative services. They say what? That was something I learned in school. Prevention is better than cure. Not only better, it's cheaper. It is cheaper. It is cheaper to avoid somebody having high blood pressure than to treat high blood pressure. So, like I said, the primary healthcare facility, the primary healthcare system is not working. So that is part of the transformation we must make with respect to service delivery. And then you have uneven access to services between the rural area and the urban area. You go to Lagos, for example, almost every corner there's a clinic here, there's a clinic there, whereas if you go to the rural area, you don't have that. Then you have another problem we have in Nigeria is that the services provided in the private sector, they are not readily affordable by the poor. Okay, because they are there to make profit. Although you have private, not for profit, and private for profit. How many of you are from private for profit here? How many of you? And don't be shy now. Let's know. I have good things to tell you. Okay. Well, thank you very much. What I'm trying to say is that whether private for profit or private not for profit, the problem is almost the same thing. He said that the quality of services in the private sector is better than in the public sector. That's a fallacy. I have not seen any empirical evidence to demonstrate to me that in Nigeria that is true. Some of the things I said you encounter in public sector, you also encounter it in private facilities. My wife and I went to see a patient sometime in a private facility, top class in Abuja. We walked around and we went to the room. Not that they knew me. We went to the room, to the bed side of this patient without being checked by anybody. Should that happen? It should not happen. Suppose we had bad intentions. We could have done that. So I think we still have to we should not gladden ourselves and say the private sector is better. No. We still haven't got the evidence yet. Because many of the problems in the public, indeed many of the things happening in the private sector, they can do, if they are here, they can challenge me, is that things are not that bad, are not that good, because some of them even exploit the workers that they employ. Do you agree with me? Find out how much many of the, I'm not saying all of you, but what you are paying some of the workers cannot, for God's sake, motivate them to put in their best. It's not possible. So that's on service. I think I mentioned 2-3 more before I move to the next. The quality of services generally poor. There is low confidence on the part of consumers in the services that are provided. And I think one major problem we have in the provision of health services in Nigeria is that we do not have government funding what we call a minimum package of health services. Do I repeat that? A government should think of how to ensure that every Nigerian, every person in the country has free physical and financial access to what we call a basic minimum package. So that if you want something above that, then you go and look for money. But there are certain common problems. Malaria, they are common things. There must be a way of providing the package free of charge. I will come to prospects. That is going to be possible if certain things are done, particularly if they pass the National Act. I will come to that. So, I have about 20 things I listed under that, but I'll leave it now and go to the next one. Human resources for health. I have Brother Bile, you started it, and I concur with you. The first challenge we have now is attitude of workers. Attitude of workers. Let's not explain things. My attitude is this because of that. No! God knows your attitude is like that. He puts you there so that you can do something that will glorify His name. If in spite of the hardship you are going through, you do what God says you should be, a shining example there, God doesn't sleep. God will reward you. He will surprise you. So the attitude of workers is generally poor. And you know Nigeria has one of the largest supplies of human resources for health in Africa. I think we are probably next. We compete with Egypt and South Africa. Egypt, South Africa, Nigeria. We are almost at par in terms of doctors, nurses, pharmacists, and so on. But there's a problem. You have them, but they are not evenly distributed. They are not also equally motivated, and so on and so forth. So let me just mention 4 or 5 other things like that. The production of many cadres of human resource for health in Nigeria is not related to the needs. Indeed, we are just producing them like what do you call it? As this assembly. I mean, where they produce car, just like a factory. We opened schools of technology all over the place. The products of schools of technology, what are they doing now? What are they doing? Many of them are roaming about the streets. They don't have anything to do. Even the staff that we say we need, you may say that those ones are not that important, but they are important. Take the case of the doctors. That was one of the problems I faced when I was in government. Our doctors now qualify. They cannot go for youth corps because no house job. No space for house job. And according to the regulation, I think if they can't do it for 2 years, if you can't get house job for 2 years, return to sender. Go back to school. If I tell you when I was there, even up till tomorrow, I'm sure by the time I get to Abuja, there will be a request for housemanship. It is like here to heaven. So we cannot even, that is part of the training. So we are not training them adequately. Passing through medical school is one thing. But then they must learn the job before you send them as youth corps. Because then they will be parading themselves and say, I'm a doctor. When it now comes to doing residency, he has done youth corps and is back and now says, I want to be a radiologist. I want to be an ophthalmologist. Hey, that is a problem. National Hospital Abuja will advertise. They probably have about 10 places. You have about 500 or 1,000 applying. That is the situation we find ourselves. So, these are some of the problems. I'll mention 2 more on this. And then go. There are many others. The other one is beauty contest. I think I've mentioned that. Rivalry. I think we have to put a stop to it. And then the other one, which I found difficult to deal with. Maybe if I go back, I won't go back again. Even if God tells me, I'm sending you there, I will say, sir, God, please have mercy on me. Let me just stay with my wife this time around. It's not quite, because what you want to do is different from what you are eventually able to do because of the distortions you have in the environment. So what I'm trying to say here is that and the problem I said we have here is there is conflict of interest. The question of private practice. And you said it yesterday, sir, and you are right. The minister is aware of that. But then, it is something that we need to deal with. But how do you do that? I'm sure, if we want to be honest, take a census of the consultants that we have in our hospitals. I make bold to say that at least, that's been very, very, very generous. At least 80% of them, they have private practice. What you said yesterday was correct. The facility, the public facility is a way of seeing the patients and then say, look, I will have more time if you come to that place. How do we stop it? And I think it's a question of the mind, like you said yesterday, sir. When you look around you, it is happening that people are taking government's time, because government paid for that time. And even some of them take resources to do that. But as a child of God, should we not make a difference? Should we not? We should. I mean, if I did, I wasn't a politician, and we are very easily contented. Thank God for that. And I made up my mind when I was going to government that I will always remember where I'm coming from. I will always remember the name and what it has taken me, by the grace of God, to build that name. And that I will not allow the office to rob me of that name. I will not say more than that. But I think the challenge to you is, you don't say it is happening. That's the practice. Is that what God says? Is that why God puts you there? God puts you there so that you can make a difference. Whether you're a lab technician or a pharmacist or pharmacy technician or whatever. Distinguish yourself. Glorify God in the way you do things you are doing. I think that is a take-home thing we have to address when we live here. And finally, on this issue of human resources for health, is the misuse of human resources. I'll give you an example. Go to my former ministry, health. We had, by the time I was leaving, not less than about 50 consultant special grade. CSG, that's what we call it, Pastor. These are people top of their profession in the ministry. It is not peculiar to Federal Ministry of Health. It is the same thing in state ministries and so on and so forth. These people ought to be in the field. I was even wondering what I could do about this. But then I said, if you try to address that, you will meet resistance. If you want to be a change agent, you must meet a resistance. Because if you want to be a change agent, things cannot remain the way they go. But I then said, some of these people, they have been there before Abraham was. They have been in the ministry for almost 50, 60 years. Would they not create more harm than good if you take them to Federal Medical Center or teaching hospitals? Except you take them through some training. Anyway, let me leave that there. There are challenges, and you know the challenges. I think I must also take note of this. The environment in which you are working, and I give you credit for that, it's not a conducive environment. No equipment, no drugs, or you have equipment. The bad light, the bad power system has gotten the equipment to break down, and so on and so forth. So I know the environment is not right. So these are some of the things that you live with. Let me go to health financing before we go to the other two, before we go to prospects. Health financing, you see, there was a meeting here. We are very good at hosting meetings, summits. It was in Abuja here that our leaders in Africa decided that, or agreed, passed a resolution, that every government at any level in any country, at least 15% of their total budget must be allocated to health. You know where we are today? You know where we are today? It's less than 6%. And that resolution was passed in Abuja here. Less than 6% of the total government budget is going into health. I make bold to say that it was during the second coming of Obasanjo that we had the greatest support for health in Nigeria. In the history of all the governments, and I've been following this since, I knew myself. Health, during the period 2003 to 2007, was one of the darling sectors. Over the 4 years I was there, the federal allocation to health increased by 200%. There was even what we call the debt relief savings. The president allocated 21% of this to health. That was the highest. But since then, we have relaxed. So there is underspending by government. Okay? The insurance coverage, although we started this in 2005, the insurance coverage is still less than 6%. So who is paying? Answer now. Individuals. Over 60% of the total health expenditure is paid out of pocket. I mean, you are sick, and they tell you you don't want to die yet. So you have to go and look for the money to take care of yourself. So the financing is not adequate. Out-of-pocket expenditure remains the single largest source. And we have development partners who are funding, who are contributing to health services. But unfortunately, at times, the priorities of the donors are not exactly our priorities. And indeed, at times, we don't even have full information about how much the development partners are spending in health. So this is part of the problem we have. Also, one or two more, insurance is limited. And what is even happening is that when government realizes there are some donors are already budgeting things for HIV, for example, government now tries to spend less. That is, the donor spending displaces what government ought to spend. Whereas, donor spending should be additional to what government is spending. These are some of the problems. And the last one I will mention on this is when you see there is a difference between budget and what? Actual expenditure. I'm sure you are aware of the controversy in the National Assembly now, where they are saying that the budget has not been, is 21% implemented. This is July. That is not correct. They say it's not correct. It's 40-something or 50-something. But problem we have consistently had in this country is that budget is on paper. What we are interested in is the actual. And the actual is always far different from what is budgeted. So these are some of the challenges on health financing. Health information system, I'll quickly just dismiss that to say that the information we have, we are not generating information on time, and the information that we are generating is not being passed up on time, and even the health information we have is not being used for making decisions or making policy. I mean, the buzzword in the world today is evidence-based decision making, but it's no longer, it's not happening yet. Then the medical products, vaccines and technologies, you are here, the pharmacies and so on. Just to mention 3-4 things which are challenges here, is that the expenditure on pharmaceutical products is about 20% of the total health expenditure. That is lower than what the percentage is for sub-Saharan Africa. And the reason is because there are so many reasons for that. So that is one problem. Number two is that in spite of the installed capacity that our pharmaceutical companies have, we are still highly reliant on importation of pharmaceutical products. By now, I think by 2015, what our drug policy said is that 70% of our essential medicines should be sourced locally. It is far from that. We are still very heavily reliant on imported medicines. And a country that does that, it's not good enough. And then, of course, if I don't mention anything, I must mention the fact that we have fake and substandard drugs all over the place. Okay, in spite of what NAFDAC has been doing. Before NAFDAC came in, I think the percentage was about 70. I think now it's been brought down to about 30 something. So they still have a long way to go. And of course, the poor infrastructure that we have, like power, water, and so on, increases the cost of local production, and therefore the cost of locally produced drugs are higher than the imported ones. There are a few other ones, and of course, one, I'll mention that and then move on. The chaotic drug distribution system that we have is incredible. There are markets for distributing drugs. We have not been able to close these markets. And of course, those markets are where you have fake drugs and so on and so forth. So there are challenges. Let me just move on to, when you talk about equipment, the equipment we have in some of the health facilities are still obsolete. They are not produced according to standard. There is poor maintenance culture. Even when I talk about the teaching hospitals where we bought state-of-the-art equipment, we were warned. Some of this equipment, you are here, you know that, they are very sensitive to light. Where power is a problem, we knew we were going to run into problem. Just, you are here. What you have to do for some of your equipment is to dedicate a generating plant so that you have constant power supply. Because if you don't do that, small, even fluctuation in light can cause a breakdown. So all these things have to be fixed. And in some hospitals, they spend millions. Just is here. Federal Medical Center, you are here. I don't know about the power situation in Bida. But a lot of the money that should go into providing services is going into buying diesel in order to, to run your equipment. So these are so, you can see why power is so important for anything we want to achieve. Leadership, governance. I will just mention three things here. I had 10, but I'll just mention 3. One is that, and I say it again, when people tell you that the Constitution says federal government is responsible for tertiary care services, state government is responsible for secondary, local government is responsible for primary, I say lie. Go and bring all the constitutions we have been writing before Abraham was, including the one we are operating today. There is nowhere that has been stated. So you have government where, unlike education, where the functions of each level had been fairly defined. For health, no. If you look at the 1999 Constitution, health has been mentioned in only 2-3 places very superficially. So the levels don't know what they are supposed to do. And for those of you who don't know, that was one of the reasons you can only do that through constitutional amendment. Okay, when I got in, I knew that was wrong. You must define the functions of the 3 levels of government. What people are saying, that federal government this, state government that, and so on and so forth, is because they read the first national policy that Olukoye Ransom Kuti, my mentor, developed in 1988, where he tried to spell out the functions. But that policy was not backed by law. So you cannot enforce it. So we knew we didn't have a constitutional amendment facing us at that time. And so what we said we'll do is to sponsor a bill. And that was one of the reasons why we sponsored the National Health Bill. We were the originator, if you don't know. But the bill that we originated, because they say, you are the one causing trouble. I didn't cause no trouble. Because the first draft that I took to Federal Executive Council is not what you have seen today. Okay? The one where they are saying doctor should be this or that, I didn't say that. The one I took to Federal Executive Council defined the functions of the 3 levels of government and so on and so forth. When I presented it, the president said, Eyitayo, this is a beautiful bill, but it cannot work in Nigeria. I said, why, sir? I was frustrated that day. He said the federal government cannot legislate for the state or the local government. The federal government can define for itself what it will do, but it cannot force any definition of functions on the other level. That took the teeth out of what we considered as a national health bill. Although some things are still there that we can, we help in a way. So that is something that I want to underscore, that there is no clear way where the functions of the 3 levels of government have been clearly defined. And the second thing is the constant leadership change you have in Ministry of Health. It said, by the grace of the Almighty God, I spent a full term, 4 years, making me the second longest serving Minister of Health. The longest serving Minister of Health was Olikoye Ransom Kuti, who spent 8 years. There was a year, 1993, I was in WHO then. You know how many ministers we have? We had 3 Ministers of Health that year. So a year where a situation where we change Ministers of Health like changing shirts. And of course we don't share vision. If it were a country whereby we share vision, and so if you are off the scene, your vision is still taking forward, there won't be any problem. But where we have these changes over time, every time, that doesn't augur well with the system. And the final thing I will mention on leadership is the high level of corruption and fraud. This is at the 3 levels of government. At the federal level, at the state level, and at the local government level. And if you have good governance, corruption and fraud will be minimum. Okay? But this is a cankerworm that we have to deal with before, so that the little money that is made, or whatever money is made available to health, whether at the federal level, at the state level, or facility level, is used exactly for, and we get value for the money that is spent. So those are the things about leadership. Now you may say, hey, given what you have said, is there any hope? I have talked to you, and I have not even presented to you 1/3 of the things that are challenges. I think there is hope. I think there is hope. There are certain things that I see as prospects, and I'll just mention at least one for each of the building blocks, so that we don't just go out of here saying, oh, the health sector is not going to change forever. It will change, and in our lifetime, in Jesus' name. If they are able to pass, first let me talk about health service delivery. If they are able to pass the national, if they are able to sign, if the president is able to sign the National Health Act that has been on his table for about 4 or 5 months now, I think one of the reasons why it's not been signed is the controversy about it. About 3 months ago, I had to appear on NTA with the current minister, with the president of NMA and so on, about this bill. And I said, the bill we have, the act, the bill, until they signed it, we have before, Mr. President, was not the original bill. Okay? But if they sign this, there are still certain benefits. Although not the best, but we can make do for now with what are the good things about it. So, I think if they sign the bill, at least two things stand out to me. Number one is that that bill guarantees the provision of a minimum package of health services for every Nigerian. The package may not be very comprehensive, but it includes mother and child care. I mean, they are yet to define it. As soon as they pass, they sign the bill, I'm sure the Ministry of Health and other organizations will be working on this. But one good thing that is coming out of this is, if it is signed, then Nigerians will be guaranteed the provision of a minimum package of health services. The second thing that will be guaranteed is that our referral system, our referral care system, that is teaching hospitals, the federal medical centers and so on, will become better organized, because they will now be supervised not by the Ministry of Health, but by what we call the National Hospital Services Agency. And we can learn, that is going to be advantageous in a way. When I was a student, and again, that was not 100 years ago, at that time we had only 5 universities in Nigeria. Okay? All those universities were supervised by the Federal Ministry of Education. But when they created more, universities, then they realized that it is now overstretching the capacity of Ministry of Education to supervise effectively. And that was what led to the creation of what? National University Commission. That was one of the things we borrowed and said, if that was true for education, we could apply that for health. Because how many teaching hospitals were there at that time? But today, you know how many teaching hospitals we have. And so that's why we said there should be this tertiary hospital services agency. So that will improve the quality of services rendered at the primary level, I think. Next is in terms of prospect. I like something that happened after I left office. That's the National Midwives service scheme. It's very good. Because of high maternal mortality, child mortality, infant mortality, some of these midwives have retired. They are not tired. So you could hire them, you could take them on, and then post them particularly to rural areas. And I think this is one thing. I think about 4,000 of them have been hired now and they have been posted. Is there any one of them here? Okay. I think they are from what I'm getting, they are doing a good job, but there are challenges in implementing that. And of course, another thing that will give me hope in terms of even distribution of health staff is this issue of, if you are training as a nurse, you must spend a year after you have trained, you must spend a year, just like the doctors do for rural posting. I think that's another thing that we guarantee that we have quality health services in the rural area. Well, there are many others, but I skip that and I'll go to human resources for health. Again, I believe that we have hope that things will change. Things will change because for health professionals, particularly those who are working in federal institutions, I think you may not be getting the best in terms of remuneration. But if you look back to about 10, 15 years ago, I know things have changed. If you compare your pay packet with what you get now, now with what you are getting then, you will see that there has been some improvement, including allowances and so on and so forth. I know the same thing has happened with other professionals or other sectors. You won't believe that in 1990, when I was going to WHO, my salary as a professor of 8 years standing was 1,320 naira per month. That was my salary per month. No allowances, no nothing. Although we had accommodation provided, that kind of thing. But today is a different thing. So we are not there yet. But what I'm trying to say is that if we keep on ensuring that the health workers are motivated, not through salary alone, but by making sure that their environment, where they work, they have the wherewithal to work with, okay? The equipment is working, the drugs are available, and so on and so forth. Apart from the salary that is also a motivator, that will change things round. And of course, you people in the medical workers, medical health workers, you have a special salary. So I think this is something that gives one some hope. Now, if I move to there's something that I should mention here. This is something that is being preached all over in the international arena. Something that is called task shifting. Okay? That is, there are certain categories of health workers that are doing certain things now. But what they are doing does not require the kind of skill that they have acquired. And therefore you can train some new cadres of health professionals to do what they are doing. And it's as if I saw this coming, because my thesis, which I wrote in 1980, was on something like this. Because I used a health center as a case study to demonstrate that yes, we have inadequate resources, but we are not making the best use of the available resources. And I was able to show in that health center that giving appropriate delegation of tasks, giving appropriate operational policies, that health center with no increase in staff can see 3 times the number of patients that they were seeing. I demonstrated that. 2 years after, there was free health services in Oyo State. And the population, the attendance in that center increased by 200%. They followed the operational policies and the delegation of tasks. That center was seeing all the patients that has increased by 200%, all of them, by 1:30 p.m. Whereas before we introduced it and they were seeing 1/3 of the patients, they were closing at 4 p.m. So you can have little, but make the best use of the little that you have. I think there is some prospect. I'm almost rounding up. I'm sorry. Thank you for your patience. Health financing. Again, that's one good thing about the Health Act. Because the Health Act, if signed into law, will provide some financial resources for primary health care. Because 2% of not the federation account, the federal, I've forgotten the concept we use there, will be set aside to fund primary health care, whereby 50% of that 2% will be used to finance the minimum package that I mentioned will be provided to all Nigerians. 25% will be spent in purchasing the drugs that they need. 10% for training staff, and so on and so forth. So that is something that is giving me hope. And of course, if we are able to scale up the implementation of health insurance, right now it covers only 6% of the population. But if we embark on some other things, if we are able to get the states to buy into the national health insurance, and of course something was flagged up by Mr. President in Isolu, just by coincidence. on December 17. That is the implementation of the community-based health insurance scheme and voluntary contributors health insurance scheme, which is the one that is going to touch on the lives of everybody. Because in Isolu, for example, right now, we are organizing and we are going to implement our community-based health insurance scheme. We have already built our own community health center because there are 14 other health facilities in town, but like I said, they are not well maintained. So we charged ourselves, the sons and daughters of Israel, and we have built a fine, almost like a cottage hospital health facility. We are going to equip it, we are going to manage it, and we are going to graft onto it a community-based health insurance scheme so that once you are insured, all you have to do when you are sick is to take your card and go there and you get services. If communities are able to do this, then that will be a way of financing health services in Nigeria. I'm almost getting home. Health information system. I think, let me skip that and say one or two because I want to round up with something. Medical products, vaccines, and technologies. I think a number of things give one hope here. We have the technical skills, we have the trained manpower, and we have the basic manufacturing infrastructure in Nigeria to be able to produce the drugs that we need without being over-dependent on imported drugs. The only thing, one of the things that the local manufacturers are facing is getting adequate financing so that they can restructure, refurbish their manufacturing plant so that they can qualify for what is called current good manufacturing practice and also get a WHO certificate that the product you are producing is very good. Because once you get that, we can now sell our products outside the country and so on and so forth. And why I think there is hope for our manufacturers to get there is that currently 6 manufacturers are being assisted in Nigeria now to meet the WHO pre-qualification standard. And in addition, I'm sure you heard about the 200 billion naira intervention fund that is being made available to support the pharmaceutical manufacturing sector. The other things here, the governance. Well, I think I have hope in the governance, that the governance will improve because we have I think the representative of the minister was, when he was reading the address, I listened to him and I've read the National Strategic Development Plan 2010 to 2015, which covers all these building blocks that I have mentioned, just like he read. And if they are able to implement all the things that are there, then I'm sure many of the problems that I have addressed will be taken care of. So that's one of the things that I think will take us there with respect to governance. And then the Bureau for Public Procurement, again, you know, that is there. It's another thing because if you know the amount of money we are saving with the setup of that bureau, it's billions of naira. Because the bureau, you have to go through due process. Things have to be evaluated so that we pay not too much above what we ought to pay to get a contract done. I think that gives us, that will make us use our resources efficiently. And of course, the anti-corruption agencies are there if they work the way they should work. EFCC, ICPC, Code of Conduct Bureau, and so on and so forth. I think they will improve the governance. And I think I must also give kudos to the civil service organizations in Nigeria. So far, we have not been listening to the voice of the people. But I think the civil service organizations are really now working with the people so that the people have a say, you know, in what is happening in Nigeria. And finally, the National Assembly, I think they have a role to play so that we have the right governance and leadership, because they are the one that passes the Annual Appropriation Act. They are also the one that does oversight functions to make sure that the money appropriated is spent in the right way. So I will stop here and then say, do we have any hope? Is this utopian that we can transform the system? And if we transform the system, can we get to where we want to get to? And I say yes. And I'm being very serious about this. Because we have an experience. And the experience we have is the one we had in 2003 to 2007. You remember that was when we came up with needs at the federal level, seeds at the state level, leads at the local government level. And the sectors were challenged to develop their transformation plan or agenda based on need. And what we did in the health sector, the one is not trying to blow one's own trumpet. But well, if you don't blow it, if the people are not ready to blow it for you, well, you better blow it yourself. And since I have the opportunity of being here, I will blow it, and loud and clear for that matter. We were one of the first sectors that developed our transformation agenda. And that was the health sector reform program 2003 to 2007. Okay? And we did this, we developed this in a consultative way. We got the blessing from the president, from the Minister of Finance, from the cabinet, and also from the National Council on Health, which is the highest health policy making body in Nigeria. So we implemented it for about 4 years. And the thrusts of, there were 7 thrusts. I think this, the development, the strategic plan has 8 thrusts or something like that. Our own had 7. And the 7 thrusts that we had, okay, are keen to the pillars of a health system. So you could see we were undergoing transformation. But the question is, okay, you implemented that for 3 years. What was the result? And I make bold to say, and I was very happy when this came out. Very, very happy. And that's what gives us hope, or gives me hope. That if we embark on the right thing, we will get there. And I'm just giving you some statistics here. One of the ways we know this progress we are making in terms of the health of our people is through this National Health and Demographic Survey that is carried out periodically, I think every 2 years or 3 years. One was carried out, can you go to that, maybe they can see it, the last, what, 2? The last, yeah. This is very important. To show that it is doable. That all we have to do is start and not allow some assaulting of policy. We continue from where we have stopped. And the National Strategic Development Plan is continuing this now. Before now, there was a break. There was a break of at least 2-3 years when not much was happening in terms of building on what we achieved. Figures don't lie, particularly if you are not the one that cook the figure. These are official figures, and you can go and check. In 2003, the percentage of fully immunized children was only 13%. Okay? That was before we started our health transformation agenda, so to call it. By 2007, it had increased to 23%. Well, that's an increase of 28% in 4 years. Another 4 years has passed, So if we had continued, I hope you are getting the point I'm making now. We will have reduced it. I mean, it will have increased by about 50-something%. That's why I'm saying we have hope. Percentage of zero immunized children, it was 41% in 2003. By the time we closed shop in 2007, it was 29%, a decrease of 29%. Neonatal mortality rate per 1,000 live births, it was 52 in 2003. By 2007, it decreased to 40. That's a decrease of 21%. Post-neonatal mortality rate, 47 decreased to 35. That's a decrease of 26%. Infant mortality rate, we were one of the worst countries in the world. It was almost 100 per 1,000 live births. 1 in 10 children, infants, were dying. But we reduced this to 75 by 2007. That's a decrease of 25%. Child mortality decreased from 187 to 157. That's a decrease of 16%. And the most spectacular one, and I will stop there because I'm concerned about this, likely because my mother was a woman, my wife is a woman, and my 3 daughters are women. And we know that maternal mortality, I mean, in the process of giving birth, we are losing so many mothers. But we were able to reduce the maternal mortality from about 1,000 per 100,000 live births to 545. That's a reduction of 48%. 48%. If we had continued, by now, we would have reduced the maternal mortality rate to by at least 75%, which is what the MDG was expecting us to do. So I have given this as a way of concluding to show that with all the things I have painted black, in spite of that, if we get our act right, and one of the things we need to get right is the role of you people that are sitting here. That wherever you are performing where you are working, you do what you are supposed to do and not get distracted by things that are happening around you. If we do that, and we do that on a sustainable basis, we will get to the promised land in my lifetime, by the grace of the Almighty God. I apologize very profusely for the long time that we have taken. Mistake people make is to invite me to talk on Friday. Friday is a day I talk more than any other days. Thank you very much. Thank you very much.
Praise the Lord. I guess we will take note of that. In addition to what he has done, permit me some might not immediately follow a very technical, although yet lucid and clear presentation like we have had. I will do something in 1 minute. I just want to point attention to the orderliness of the presentation. And for that to serve for us, let it serve as some of the personal cues that we can take away from here. And I believe that even as we are strategizing on contributing our quota, we have a roadmap that is sort of defined, and you could see it used repeatedly. Our keynote speaker introduced the goal of healthcare delivery, and immediately thereafter introduced the 6 the 6 building blocks of the healthcare system, which he called service delivery, human resource for health, or for some other people, manpower in health, health financing, health information management, medical products, vaccines, and technology, and all of this within the central wheel of leadership and governance. And when he was looking at challenges, he traced challenges from the perspective of each block. When he was looking at prospects, he looked at prospects from each of the blocks that had been identified. And this will be key for us in keeping a trend of thought and in keeping a focus of response as we go through issues. I just felt it necessary to present that type of a summary to us, that this is what we have had. Thank you very much, sir. We will now call on Dr. Mrs. Lambo, who is just going to give us a little tip and some brief on life support skills.
Praise the Lord. I want to talk about medical emergencies. I normally train on how to respond to medical and fire emergencies. The fire emergency seems to be more attractive to people than the medical emergencies. But medical emergencies can arise as a result of fire disasters and so on. So we train people on how to be safety conscious. Whether it is fire accidents or some other accidents, there are basic procedures that you need to follow. For the medical doctors who are here, and probably for some nurses who have been trained to assist doctors in attending to patients in the hospital, some of the things I might be saying may be a little bit insulting to your intelligence. But I want to talk to the generality of the people who are here. I would also like to say that a helper is usually stronger than the person being helped. So when you say the wife is supposed to be a helpmeet to the husband, I want husbands to realize that the wife is sometimes stronger than the man. Praise the Lord. Oh, no. It's not colorful. When emergencies occur in any form, it doesn't wait for specialists to attend to such emergencies. Are you hearing, everybody? Okay. A medical emergency will not wait for a doctor. It will not wait for a nurse. It will not even wait for people who are skillful in managing emergencies. So my stand has always been that every one of us should be trained on how to attend to medical emergencies. Some 11 years ago, we just got to Abuja. We went to a cyber cafe because we hadn't set up our internet. And suddenly a young man who is an undergraduate at the University of Abuja collapsed, started foaming in the mouth. And everybody was wondering what was happening. And they didn't know what to do. And then somebody who I presume must have been a pastor said, I rebuke the spirit of death on this young man. Oh, I said, I know how to answer that. Amen. And then he started praying. I was also, rebuking and doing everything possible. I'm sure God has a good sense of humor. God will just be saying, I have empowered you. All you need to do is to acquire knowledge. Hosea 4:6 says, my people are destroyed for lack of knowledge. Each and every one of us can help in emergency situations. In this country, I like one thing about Nigerians. We are very sympathetic. if an accident occurs, people will rush to the scene and do whatever they can do to rescue the situation. But most of the time, we don't know what to do. In some cases, doctors will even panic. In my training, I normally show a convoy accident. It's a small video clip of 5 minutes, and it's usually very, very powerful. What happened in the accident was that it was a convoy, and many cars were involved, and people were taken out of the scene in different ways. One leg here, one leg there. And that is a wrong way to carry somebody who has a medical emergency, because you are not sure whether bones have been broken, fractured, whether there's a head injury or anything. And then when a car somersaults, for instance, medical doctors, you will confirm this, sometimes it is possible for you to leave that. The best thing to do will be for you to leave that person where you find the person, unless the person is in danger. You're not supposed to turn the car the other way. Anybody can experience this on the highway. It doesn't have to be a doctor. The first thing you should know is that if there's no need to move anybody who has a medical emergency, don't do so until a professional person arrives at the scene. Medical doctors, you agree? You agree. In most cases, many laymen and women complicate issues before they bring them to you. So the people who appear at the scene are usually called first responders. They are the people who are willing to help. Not everybody can help, but some people are strong enough to be able to carry people from one place to the other. What we normally advise is that by way of helping, only do what you think you are skillful to do. A car may be about to catch fire, for instance. The best thing for you to do, you can move the person away from the scene, but carry the person in such a way that the body parts are together. Correct, medical doctors? Please confirm. Very correct. Thank you. But let me go to the basics. I'm just preparing to train the leaders of my church family worship center in Abuja. Thank God I have had the opportunity of training security men, church workers, secondary school teachers, and I've even gone out of the state to even speak to the conference of pharmacists. I don't know whether some of the pharmacists who are here will be familiar with what I did in Akure many years ago. We created a scenario where somebody slumped in our midst. It was a plan. And I just asked the young man, I said, as soon as I start talking, just pretend as if you are collapsing. And the guy fell down. Many pharmacists did not know what to do, except that one person said, bring water. And that was the wrong thing to do. Pour water on top of him. I had to say, no, don't do that. Leave him. After the convulsion, if he comes to himself, then, somebody can take him to the hospital. That's a useful tip. For somebody who is convulsing, you don't just start putting something in his mouth. Just make sure there is nothing around him that can harm him. After convulsing for a few minutes, he will stop. In serious convulsions, maybe after another 10 minutes, he will continue again. That's just a simple tip. And there are many tips that we can give. We normally do this kind of training for 2 days, 3 days. And I'm going to compress this to just a few minutes because of lack of time. I'm not going to say much about that. But for the laymen who are here, let me tell you that I didn't prepare to do this presentation today. But we're going to define what you mean by emergencies. And it could be in fire, it could be any type of emergency. This is just general knowledge for everybody. I've also had the opportunity of training medical doctors and nurses and admin staff in some teaching hospitals. When you have an emergency, you won't be followed. Okay. It's not very clear. How do you define an emergency? It is in a crisis situation, a state where there is a difficulty, particularly difficulty in breathing, or the person cannot get out of that situation very quickly, a state of predicament, a panic situation, then a dangerous situation. In that case, attention is needed almost immediately. It means you have to do something. That situation requires urgent attention. How do you recognize emergencies? Thank God we have our different senses. We can see emergencies. We can smell some odors. We can look at appearances and we'll be able to tell, even as laymen. You know when somebody is lying unconscious and that person cannot respond to you even when you tap. You must always make sure that you tap. But before we go into that, I'd like to tell you that in the case of emergency, you need to keep calm. I know it is difficult. Even me, I've had the experience after several years of training on emergencies. In the U.S., my daughter felt, I was strong enough to take anything. And she insisted that I must be around when she was having a baby some years back. And we went to the hospital together. And, the receptionist was asking, name. And I said, Eyitayo Lambo. As if I was the one who was going to deliver. That's a state of panic. I was already panicking because I wanted her to be attended to. I like what Brother Bile said yesterday. I don't know why they call patients patients. They are the most impatient people on the surface of the earth. We are impatient. We are always impatient. We want to be attended to quickly. And I said, Eyitayo Lambo. Then I remembered, it wasn't me who was supposed to be attended to. And I said, Abimbola Lambo. This is a married woman. Her name is no longer Abimbola Lambo. She's the wife of somebody. But again, it was out of panic. So what we normally advise is that you should not panic in any case of emergency. Because it becomes difficult for you to think straight and to do the right thing at the right time. A preacher, to be precise, Professor Adegbija in Ilorin once preached that many of the things you are concerned about, that you fear, are the things that had not happened. Whatever has happened, you have no control over it. We are anxious because of this, because of that. I don't want my child to die. I don't want my husband to die. If it has happened, there's nothing you can do about it. And besides that, not a strand of our hair can fall without God's knowledge. And in the Bible, there are 365 fear not. So if God is telling us not to fear, why are we panicking over many situations? It will not help. It will just compound matters. What we normally do in most cases when we are faced with a crisis situation is that we panic and we don't do the right thing. Moreover, I want medical doctors to train their associate staff on how to care for medical emergencies. Let me begin with the pharmacist. In most cases, I try to study the pattern of health-seeking behavior in Nigeria and in some other African countries. What we normally do is self-medication. After that, if the situation is getting out of hand, you can consult anybody around. It could be your grandfather or your grandmother who doesn't know anything about your condition. Okay, you ask some people to help you. Then after that, if there is no hope, maybe you go to a faith healer, a pastor, somebody. Then the next place is a chemist shop. I don't know how many of us will be asking if there is a pharmacist in a pharmacy or a chemist shop before we have to buy a particular medication and so maybe a neighbor has recommended something, you go there to buy. And what I was telling the pharmacist some years back is that coming to the chemist shop, coming to the pharmacy, means there must be a point of contact between patients and you. So you must know how to respond to medical emergencies. Somebody could come to your clinic or pharmacy and the person becomes unconscious. You must know what to do. I won't go into the details of what you're supposed to do because today is not a day of training. It's just to create an awareness that everybody within the hospital setting and even outside it need to know the basics about emergencies, medical emergencies to be specific. Outside the country, doctors will not normally take your BP. They will not do many things. We underutilize the skills of our doctors in this country. Nurses and associate staff are supposed to do all the preliminaries, take your weight, ask you questions about your history and so on, before they even hand you over to the doctor. Doctors will also confirm with nurses and other associate staff about the health condition of a patient. And then they can brainstorm. It's supposed to be teamwork, just like what my husband said. It's supposed to be teamwork in the hospital. Don't lay all the burden on yourself. I know some doctors who got angry in the past just because a nurse was asking questions from the patient. It has been happening. We need to train those who surround us, including members of our household. If there are skills that you have to rescue people in the event of any medical emergencies. I have told you we have our eyes to see. We can hear noises. We can see the appearances of people. We know when people are in difficulty. We can smell. I think we should harness all these skills that we have that God has given to us to help people in need. And the most important thing you can do as a layman, whether you are a nurse, anybody working within the hospital setting, is that you know where to direct a particular patient. You should be able to assess quickly what is wrong and know what doctors to call and so on. I'll move on quickly. When you want to attend to any emergency, particularly medical emergencies, you need to do certain things. Sorry, it's not very clear on the screen. You check the scene for your own safety as a responder. Whether you are a doctor or not, it doesn't matter. Because you want to help and you want to be in a position to be able to help others. So your life must not be in danger. We have had people on the road when there's a road traffic accident. The people who have accident may not die. It is those people who are helping on the road that an oncoming vehicle will just clear. God forbid that one should happen to any one of us here in Jesus' name. Check the scene for your own safety. Try to determine the cause of the situation, assess the situation quickly, and then call if you can call. In the US, they'll say call 911. In Nigeria, the Lord will help us because God knows your mind. FRC has just launched the number 112, something like that. Please find out. There are emergency numbers now that you can call. There's fire emergency that you can also call. Familiarize yourself with such numbers. Whether you're on the road, in the house, in the office, anywhere, you must be able to call such numbers. Have the numbers of doctors, nurses, and so on ready that you can easily call. More importantly, don't be a hero. When you come to an emergency situation, ask for help. From the little knowledge I have, when somebody becomes unconscious, the person becomes heavier to even carry. So even when you want to move the person from the scene of the accident, it becomes difficult for you to do it alone. So you must always call for help. Then you care for life-threatening conditions. This will be about the last thing I will say before I stop, because I know our time is fast spent. When you meet an emergency situation, particularly in a road traffic situation, accident, There are people you should care for almost immediately. There are some who can wait. In a particular scene of an accident, some people will be crying, "Hey, I'm dying, oh, come and help me," or "I'm dead." That person is not dead. If that person were dead, he would not be able to shout. The one who lies lifeless and the head is like this is the one you are supposed to help first. Why? Because with the head like this, that person will not be able to breathe properly. He could still be breathing a little, but after some time, that breathing may stop. So you need to help that person. That is, in mass disasters, when you come to a scene and there are many people to be helped, you prioritize your care. Another life-threatening condition is heavy bleeding. Medical doctors, you agree with me? If there is heavy bleeding, you must try to stop it. Like I said, I'm not going to give you full training. I'm just giving you a tip of the iceberg. When you come for our training, we do exhaustive teaching. We show you films. We actually make you practice some procedures. So I don't think I will have the benefit of that time to do everything. So you prioritize care. You attend to people who are bleeding profusely. Attend to people who are lifeless. Maybe there's something you can still do. There's what we call CPR. You do rescue breathing where there is need to do that. You do compressions, that is, you compress the heart. You cup your hand like this and look for the center. Look at the nipple. Clench your fist and try to pump. What are you doing? You are trying to jumpstart the heart, because the heart pumps blood to the rest of the body. And how can it do that? And what's the essence of that? It is because it is blood that carries oxygen that runs through your body. And without that oxygen coming into you and you exhaling carbon dioxide, life can soon get out of the patient that we are talking about. What do you do to even allow air to come in before you do rescue breath? Till the head of the person, lift the chin, and then we normally use breathing barriers to teach, but not many people will have the benefit of breathing barriers in their pocket. As I'm here, I have breathing barriers in my pocket. I have gloves, because you are supposed to be conscious of the fact that diseases can be transmitted through body fluids. So you use gloves where they are available. You can buy cheap ones and just put them in your cars if you're willing to help in any situation. If you have been trained properly, you can assist. But while you are doing that, don't infect yourself with other people's diseases, and don't pass your own to other people too. Because God knows your heart. Even if you do direct mouth-to-mouth resuscitation, you will not catch any disease in Jesus' name. But try to prevent infection. You can use your handkerchief. God will not allow any germs or bacteria to pass through the handkerchief. Let me tell you a final story. Somebody working with my husband while he was minister was moving to his new house. And I told him, I said, "Gee, what do I give you?" "Okay, I'll give you 2 fire extinguishers." Because he's a pastor, he said, "I'm covered by the blood of Jesus." I said, "Okay, in spite of that, we may need to fulfill all righteousness. Put something in your house to help you." For several weeks, I got the 2 fire extinguishers, and he refused to come and collect them. One day he came to the house, and I told the boys in my house, I said, "Go and put the fire extinguishers in his house, in his car." And they did that. I just told him by mouth. To tell you that he did not take that seriously, he did not even inform his wife. 2 years after that, I was out of the country, and he was trying to call me. He said, "Madam, you said it." The mechanic was working on my car, and there was a spark. The car was about to catch fire. So I decided to use your fire extinguisher. Now, after giving him the fire extinguisher, I said I would train you on how to use the fire extinguisher, because many people have fire extinguishers, they don't know how to use them. And he didn't call me, but again it was covered by the blood of Jesus. He is supposed to refill of the fire extinguisher every 6 months. Remember I said he kept them in the house for about 2 years. Then he tried to use it by just removing the horn of the fire extinguisher. The fireman said if he had succeeded in removing it, the whole thing would have exploded and it would have been amputated. So indeed it was covered by the blood of Jesus, because he made that confession. But a time of ignorance God will allow to pass. Gain knowledge. The Bible says that you have to study to make yourself approved. Is that not correct? So for every health worker here and for others around you, in your house, in your household, in your office and everywhere, let them know the basics of how to attend to medical emergencies or some other emergencies so that you may save lives. Thank you very much. If you attend my training in future, we'll tell you more and we'll do a lot of exercises.
Thank you very much.